Welcome to Coalition Conversations, brought to you by the Greater Philadelphia Business Coalition on Health. My name is Tom Belmont, the President and CEO of the Coalition, and your host for these conversations, highlighting areas of innovation and opportunity for employers to focus on in building innovative and sustainable health benefit programs for their employees and dependents. Today's conversation is part of a series of three, each focused on various aspects of obesity, weight loss, and GLP-1s. Through each of these conversations, we hope employers will emerge with information and ideas to build a sustainable program that integrates the best practices and aspects of promoting long-term healthy lifestyles for those dealing with obesity. This is a critical issue today as GLP-1s have become such an integral part of the conversation in the treatment of obesity and other disease states, and are viewed by some as that once-in-a-lifetime innovation that could bend the long-term cost curve. Reconciling the long-term potential to bend the cost curve with the financial challenges of today will take data and planning to build a sustainable long-term approach. As you will hear in this session and the next, the data is a challenge. But today, in our second installment in the series, we have two guests who will highlight how each of their organizations has combed through a tremendous number of data sources to develop insights to help advise employers on current and future trends, as well as highlight directional best practices in plan design toward building a sustainable strategy. So I am pleased to welcome Alex Pfau, Vice President of Health Solutions Analytics and Actuarial Market Leader for Philadelphia Aon, and Lindsey Schapiro, Associate Director of Peterson Health Technology Institute. I went through your backgrounds because I think this is such a critical area, and to have two experts like you both, as part of this conversation is fantastic for our members. So really appreciate you both being here and being part of our conversation today. So Lindsey, maybe a little bit, I know folks are probably very familiar with Aon, but maybe a little bit of background on PHTI.
Yeah, definitely. Thanks, Tom. It's great to be here today. Unfortunately, not in the same place as we had hoped, but New York City is not so far away. Um, so PHTI is an independent nonprofit organization that evaluates digital health technologies. There's a lot of tools, digital health tools that are on the market being sold to purchasers, whether that's employers, payers, providers. And at PHTI, what we do is we seek to help them answer a few critical questions about these digital health technologies. Do these solutions work, and are they worth it? So, as part of our work, we conduct a systematic literature review and budget impact analysis. And we've done evaluations to date on areas with digital solutions like MSK, diabetes, hypertension. And as you mentioned, as part of my bio, part of the work that I do is I talk a lot to our Purchaser Advisory Council, which is comprised of HR leaders, benefit leaders, and I hear from them about what the clinical areas they're focusing on, what's driving costs, what's keeping them up at night. And really, over the past few months, what we keep hearing is the conversations inevitably going back to GLP-1s. What do we do about it? How can we cover it? And we've also heard that employers are constantly being pitched by different digital health solutions saying, we can help with access, we can help control costs. So a lot of our Purchaser Advisory Council members, and just in conversations we've had, people are asking us, what are you hearing? And so we really set out to understand the market. But what we quickly realized is that the traditional evaluations that we have done to date, it would be a little bit difficult given how new this area is and how quickly things are changing. And so what we decided to do was to conduct a market analysis and really understand what different strategies are out there that employers can take and how they can think about managing their GLP-1 coverage. So our analysis, as part of that, we spoke with a number of experts. We did a deep dive into the published literature and again spoke with members of our Purchaser Advisory Council. And our goal is to help employers evaluate these virtual weight management solutions and help them design clinically effective, financially sustainable benefit programs. I know that was a lot, and I'm looking forward to digging into that a little bit more. But for now, I'd love to hear a little bit about Alex and the work that he's been doing with his colleagues over at Aon.
Well, and Lindsay, it
Yeah,
sounds
great.
like we have a dog that's trying to dig into the work already, so it's all good.
Yeah,
Sorry, Alex.
one of the drawbacks of using the phone. So apologies for that. But yeah, just thanks, Lindsay. So kind of building on what you say, what you said, there really isn't a lot of data around the cost impact of GLP-1s yet. So earlier this year, Aon released one of the first workforce focused studies on GLP-1s. And our study is unique for a few reasons. So I think first and foremost, it's independent, right? So I think that's important when we're operating and talking about the PBM space. Secondly, it's using data for commercially insured lives. So we're looking at over 50 million lives, and I think commercially insured lives make the study relevant to the employer health plans and to the applications that PHTI is considering here. So next, I think it focuses on the GLP-1 impact on medical spend. So we're looking over a 2-year period. So there, I think from a lot of information out there, not much of it is focusing on the actual medical spend. And then, I think just to round that out, we're using a pretty innovative methodology. And this is a matched cohort study. And so with matched cohort studies, the match is really, a critical part. So we're using Aon's cost efficiency measurement model, and it allows us to look at such large data sets across multiple years. And it really helps us to have a high integrity match between the treatment and control groups so we can have confidence in the study.
And Alex, the treatment and control groups. I think, if I read the studies right, it was like 50 million lives that you guys dug into, and 139,000 in one group, 139,000 in another, roughly. If that's
Yeah,
fairly
that's right.
accurate.
So we're looking at that large data set. That kind of translates to about 139,000 GLP-1 utilizers. And then those are each matched. And so they're matched, you're looking at demographic data. But I think one thing that's a little special about our approach here is that we're also looking at claims data for individuals, right? So we can match someone up that not only has like the same demographic characteristics, but some of the same health conditions and similar baseline costs.
Yeah, and I don't mean this as an advertisement for Aon, but I think it's important for folks who don't know. I mean, Aon's made a pretty significant investment into bringing all of your data together so you can do studies like this. So I think it's great to see this come out, and or at least the initial reading come out. So what did you find in the data?
Yeah. Well. So first, I think what you would expect as far as comparing the costs. So initially, the cost for the GLP-1 group are higher than for the non-utilizers because the drugs are expensive. But what we did find is that over time, particularly in the second year of treatment, the trend for the GLP-1 utilizers was considerably lower. So we observed that was about 7% lower medical trend for the GLP-1 users. And then secondly, we observed a really meaningful reduction in hospitalizations. So a 44% reduction in inpatient hospitalizations that were caused by major cardiovascular events. And I think one thing really important to keep in mind there, specifically around the hospitalizations, but also contributes to the trend, is that that the average adherence for this population was about 71%, and you lose some of the favorable impacts of the medications as that adherence goes down. So I know that's a really one of the challenges kind of on the forefront for managing these GLP-1s.
Absolutely. No, that's great. And I think we'll talk a little bit later with Lindsay about some of the, some of the things they've brought out in their study of studies that, looks at adherence as well. Um, eh, Alex, I guess, and I know a number of us have, tried to, kind of cajole our way to getting a full copy of the study. So really looking forward to when this study comes out in full. Um, any other notable
Well, Tom, so yeah, so that was we released what I just talked about in May. And one other distinction there is that due to the timing, right, like Zepbound hadn't really hit the market in that 2-year look back period. Um, so it combines diabetic and weight loss population. And so we're in the process now of updating that and refreshing it with more information. And we should be releasing that hopefully in January, where we're actually breaking out the diabetic and weight loss groups.
That's
But I
great.
can tell you just from what we've seen so far, the update, maybe a little sneak peek is the results are pretty similar. And they're consistent across the diabetic and the weight loss groups. So I know the focus here is really on obesity and weight loss.
But the comorbidities mean so much in the, kind of the discussions that we're having. So, thanks for that's exciting news. Anything else that you've seen in the data so far?
Yeah, I think interestingly, we're seeing, and I guess you might anticipate this, but we're seeing mixed impacts for various types of claims. Like for cardiovascular, for example, we're seeing lower incidence of those types of claims, of course, tied to appropriate adherence. But I think interestingly, we are seeing a higher incidence of several claim categories. So like general labs and testing, we're seeing costs a little bit higher, and we're also seeing higher MSK and like gastrointestinal claims as well.
What, as you dig into that data, what do you think is driving the higher utilization?
Yeah, it's a good question. So I think it's really two things. I think y- not only monitoring, but there's more patient physician engagement. So there's a certain level of extra monitoring because you're on the medications. But I think there's also an element where people are losing more weight. They're becoming healthier and I think more empowered to take control over their own healthcare journey. So I think that's one area. And then I think a second is that there's certainly some direct side effects to the medications. And so I think like most notably there probably like GI side effects come to mind.
It was interesting in the last conversation in this series, we'll hear from, one of our employer members, and she's actually been on GLP-1. She's lost about 100 pounds on GLP-1s. And I think what was interesting will be interesting in the discussion with her is the fact that she looks at her own personal bills in addition to looking at what the claims are for the city, and has seen, the exact impact that you're talking about. There are claims that are up because, hey, I'm at the doctor's, I'm doing different things than I was doing before. But a lot of those, the admission she would have once a year, some of the medications that she would have, they're gone. So she said, I used to be a $25,000-$30,000 a year claimant. I'm now $2,500 to $3,000. So, it's a huge difference for somebody who had, multiple chronic diseases. So great observations, Alex. Thank you. Hey, Lindsay, I know your report focused on ways employers can leverage digital solutions to, look at how they structure their GLP-1 benefits, their overall weight loss program. Um, Talk a little bit about, I found the insights you guys developed in the reports just fascinating. So maybe talk about a little bit about what you saw in there.
Yeah, for sure. So I'm actually really looking forward to the next round of this podcast because I really think employers are in just such a challenging position right now. Like you said, these drugs are can be life-saving and life-changing for a lot of people, and employers want to be able to provide them. Um, but it is difficult given their budget constraints, and I think that there's a reality component to that. So just when we think about offering the benefit for people who want to take GLP-1s for weight loss, right? We heard that fewer than 1 in 5 employers covering GLP-1s right now are covering it for weight loss. But we know that the employee demand far exceeds that, right? And so how do you find that right balance to make sure that you're offering both in terms of access and you're meeting the demand of your employees? And so our goal with our report was to really help employers think about how to manage their benefit programs to make it accessible and affordable.
I thought that was interesting. There's a chart in your analysis that goes through all the different things that either employers have put into place or are thinking about putting into place, which I found really interesting. That I think it was I don't PAs weren't really that high up on the chart, if I remember right. I might be misremembering that, but there were some specific strategies folks were looking at and, really doubling down on as ways to try and, keep the coverage without, but also manage the financials.
Yeah, definitely. I think we one of the ways that we were thinking about it is um, employers are thinking about how can I support the people who are on the medication? And then a separate question is of the people who are looking for the medication, are there other alternatives for them? And if somebody wants to choose to go off the medication, how can we also provide support to them as well? So we talk about initiation, maintenance, and supported discontinuation. And there are different strategies that employers can take to address a patient at different parts of that journey.
Oh, great observations. And I know to your point, that's been we hear anecdotally from our employer members, folks are, they're ticking up the BMI or they are pulling the rug out completely. And, if I pull out the rug completely and I've invested $1 million in GLP-1s for weight loss, I've now lost $1 million. So great insights. Thank you. Go ahead. Sorry. No, no, go get them.
I was just going to say, I think, adjusting the BMI is one example. And then another one that we heard a lot about is actually narrow provider networks, both of which are interesting. They work for different reasons, but the narrow provider network we heard particular examples of that added step of kind of routing people through an approved network of providers can actually, in and of itself, be a way to kind of um, streamline the process and prioritize the acuity of the patients who are going to receive the medication.
Mhm.
Because we heard that up to 60% of people who were rerouted sometimes drop off. And so they're not filling their script. Is it because that they feel like they actually don't need it, or is it because um, there's too much of a barrier? And so there's also access questions that come around with that as well. Um, but with any of these strategies, the question of is this going to impact my rebate if I put these strategies into place is also something that we heard a lot from employers. And so that conversation is ongoing and important for employers to have um, with their PBMs and as they work through their own decisions.
It is
Yeah.
it's a complex marketplace right now. We did talk about in the one prior to this, with some of the pharmacists is just how quickly the manufacturers are looking to evolve their models from direct to consumer, direct to employer, all kinds of different pricing, wraparound services, no wraparound services. So it is a complex world for employers to figure out what their strategy is going to be. I know, Alex, kind of in your study, you guys looked at, some of the challenges employers have around the cost of these drugs. Anything you wanted to add to what Lindsey had talked about?
Yeah, that's right. I mean, I think the costs are continuing to change. The PBM strategies are continuing to change, as are the manufacturers. So like our data is looking at the paid claims, right? So that doesn't include rebate information. So I think getting at like the actual acquisition cost of the drugs can be a challenge. And our study made it like a blanket assumption for overall rebates, but it can vary really widely based on an employer's individual contracting with a PBM. So I think the rebate implications are really something to keep an eye on, and certainly like a complicating factor.
So, Alex, thank you very much. I think that makes all the sense in the world about what's going on with some of the costs. And Lindsey, I think as employers try and manage through all of this, some of the points that Alex brought up, some of the points that you brought up, in your report, you going through all the analysis that you did, you came up with some specific recommendations for employers as they think about including GLP-1s as part of their overall strategy. So maybe talk through some of those outputs.
Yeah, definitely. So some of the recommendations I sort of already touched on about establishing clear clinically driven eligibility pathways. Another thing that came up a lot was about requiring participation in some of these like behavior, nutrition, lifestyle change programs as a condition of coverage. So we heard that a lot. Some people are requiring their employees to engage in these lifestyle management programs, and some are actually going a step further and requiring, if their employees engage, they'll actually offer sort of like a copay incentive as an added incentive on top of the benefits that they could get from the program. Other recommendations that we have is that as employees are thinking about all of the solutions that are being brought to them, and you know make sure that first and foremost that employers are thinking about what solutions they're already contracting with, right? Additional point solutions. We've all heard there's a lot of point solution fatigue. And so if solutions that they're already contracted with have a GLP-1 offering, have a conversation with them about how can we structure an additional program through our existing partnership to create something for the employees. Whether it's a new contract or a contract with an existing vendor, one thing that we strongly recommend is to think about, are there ways to make these contracts more performance-based? At PHTI, one of the things we think about a lot is contracting for value. And we're actually putting out some work I was going to say in the fall, but in the beginning of the new year about performance-based contracting. And we heard a bit about this as it relates to GLP-1s, but I think the market's not quite there yet. But the opportunity to contract for retention or weight loss and putting that as goals for people who are participating in the program is a way to make sure that the way that these dollars are being spent by employers on these digital solutions is really ensuring that they're getting the value out of it on the other end. Down the toilet, right? And it's not a great way of saying that, but we want to make sure that people who are choosing to go on the medication stay on the medication, and the people who are choosing to go off of it are aware of techniques and approaches to help sustain the benefits that they've received.
Great point. And a great visual. I mean, nobody will forget that visual. So, hey, Lindsey, just a quick question. In the report, one of the things I found just fascinating was the data that you guys pulled to talk about, the impact of drug shortages in 21 and 22, and what that did to, or what's inferred it did to persistence rates. Maybe just talk a little bit about that, and how you guys viewed that information.
Yeah, that point's actually received a lot of attention since we published our paper. That data is actually comes from a Prime Therapeutics study, and it was really the first place that I'd seen put out this hypothesis that the supply chain issues at the time, 2021, 2022, could be impacting the persistence. And I think that over time, we'll need to do additional research and just look at the trends over the next few years to see if that 1 year persistence data really does change. Because as you can see in the graph, that in 2021, 2022, I think it was about 30%. And then up into early 2024, persistence at 1 year for weight loss was closer to 60%. So that's a really big difference. And maybe that also has to do with different supports that people are receiving um, to manage side effects, or maybe some of the side effects are more well known, so people are aware before they go on what um, they may face. And so I think that there's definitely more research to be done, but I think your point stands that it does initially cause a bit of hesitation if you see a number 30% are not going to stay on the medication. That's a lot of money for employers to spend. And to this whole conversation, um, there's real clinical benefits that people can get from being on the medication, but staying on them, maintaining the weight loss, maintaining other healthy lifestyle habits are critical as well.
So the conversation with both of you has been fascinating. And I think the studies are fascinating from a lot of different perspectives. But, to your point and to many of the points you both have made, as an employer, there's so much information coming at you that you've got to just stay up on to make an informed decision and build a long-term strategy. So as your mic drop moment, what would be your one piece of advice to an employer who's looking for a sustainable long-term strategy? And Alex, I'll start with you.
Okay. Yeah. Well, I mean, I think as a healthcare actuary, you know what I might say here. But staying on top of the data, right, is really critical. I talked a little bit about making sure you establish the right metrics, right, the right priorities, and so establishing the right metrics that you want to track and tracking them. And really, I guess one piece of advice that I would say is revisit your strategy frequently, because the strategy that you establish right in 2025 for 2026, that might not be relevant in 2027 when we have so many changes just kind of across the landscape.
Great.
Is it
Lindsay?
my mic drop time too? um, I 100% agree with Alex. I think taking an evidence-based approach and looking at data um, to really identify where along a patient journey um, somebody is, and how can you help patients stay on the treatment? How can you support them in their decision to go on the medication or not? And if they choose to discontinue it, how can you continue to support them and meet them where they are?
Yeah, both of you, great advice, great mic drop moments. And I think some of the themes you brought up are themes you'll hear in the next installment as well about, as we bring in two of the employer voices directly. But appreciate all the data that you guys brought to the table. The going through and looking at so many different data points has been so informative. So thank you both for being here and having this conversation. And appreciate all the hard work, and we can't wait to have you back to talk about updates to your studies. So
Thanks so
thank you.
much.
Yeah, great. Thank you.